So today I'm going to talk to you about some research I did over the last year, really looking at the prevalence of NF2 in individuals with Phelan-McDermid syndrome, and specifically in Phelan-McDermid syndrome caused by a ring 22 chromosome. You could go to the next slide. So before I tell you more about our project, I'm just going to give you a little bit of background about Phelan-McDermid and about ring 22 chromosomes, and then we'll go through the study. Next slide. So Phelan-McDermid syndrome, which I'm sure will be a review for a lot of those on the call, is a rare neurodevelopmental disorder described relatively recently and characterized clinically by moderate to severe intellectual disability, absent to severely delayed speech, hypotonia, autistic-like behavior, and some common physical features that include dolichocephaly, flat mid-face, wide brow, wide nasal bridge, deep-set eyes, full cheeks, puffy eyelids, dysplastic toenails, which you could see there. Although the physical characteristics are variable, and so sometimes making the clinical diagnosis is particularly difficult. Next slide. So Phelan-McDermid syndrome is caused by rearrangements of 22q13.33, and so that could include terminal deletions, interstitial deletions, duplications, ring 22 chromosomes, what we'll talk about today, and rarely balanced or unbalanced translocations. Additionally, this syndrome can be caused by variants in SHANK3, so the diagnosis is typically made genetically via microarray analysis and then rarely sequencing. You could go further. So to give you a little bit more background about ring 22 chromosome, they're just like what they sound. They're, you have distal breaks in the P and Q arm, and you get spontaneous fusion of the P and Q arm. And this is important because they're identified via chromosome analysis, and so on microarray, you would not be able to tell if a person has a ring 22 chromosome. The other important thing to realize about these ring 22 chromosomes is that they're mitotically unstable, and so they're spontaneous loss with subsequent cell divisions, creating a monosomy 22. So previous estimates have estimated that about 14% of individuals with Phelan-McDermid syndrome have a ring 22 chromosome. Go further. So clinically, why is it important to recognize these? Well, it's because of the association of rings with tumors. And this was first recognized in ring 22 specifically in 1986, when they described the first association of a ring 22 chromosome in a patient with multiple meningiomas. He was a 20-year-old institutionalized male with severe intellectual disability, hearing loss, microcephaly, worsening apathy, anorexia, and seizures, and ultimately death at 27. On autopsy, revealed large cystic meningioma at the cerebropontine angle, compressing the medulla and likely the cause of his demise. But on autopsy, several other dural meningiomas were found. And so this is a picture of just, you can see the ring 22 chromosome on the top, and then from this. So after this initial report, there were several similar studies that were published, all in patients with intellectual disability delays and a ring 22 chromosome. And not only meningiomas, but specifically other neurofibromatosis associated tumors. So just as a review, neurofibromatosis type 2 is a benign tumor syndrome. It's characterized by different types of predominantly CNS tumors. Classically, it's a bilateral. You can also have meningiomas, pendymomas, and very rarely astrocytomas. So it's an autosomal dominant disorder. It's caused by variants in the NF2 or the Merlin gene located on chromosome 22 at Q12.2. And Tumorigenesis is thought to occur via two-hit mechanism. So the first hit is the inherited change in NF2, and the second hit is mosaic loss of that second allele, and that's what triggers tumorigenesis. So despite the association with NF-type tumors in these patients with ring 22 described in the literature, it was initially thought that tumorigenesis was just triggered by mosaic loss of the ring 22 chromosome, and that was all that was needed. And that was because there's multiple tumor suppressor genes on chromosome 22. However, it was not until 2007 that sequencing of the tumor tissue specifically showed that, similar to congenital or inherited NF2, you need biallelic loss of the NF2 gene. So the first hit is a mosaic loss of chromosome 22, and then obviously you lose NF2 in that, and the second hit is a sequence or structural variant in the second NF2 allele. And go next. So all that being said, because of these initial results, it's long been appreciated that there was at least theoretical concern for NF2 in individuals with Phelan-McDermid syndrome caused by a ring 22. However, the prevalence in clinical and radiological findings associated with development of NF2 hadn't been clearly described. So the goals of our project were really twofold. One was to really understand the percentage of Phelan-McDermid patients, or the population at risk for NF2. So to do this, we reviewed the Phelan-McDermid International Registry, and this is a registry where patients and families, they submit their genetic reports. And so we looked at this and tried to see how many patients would be at risk for a ring 22 chromosome, or had a ring 22 chromosome, excuse me, and theoretical risk for NF2. And the second characterize the prevalence of NF2 in Phelan-McDermid caused by a ring 22, and identify the clinical and genetic and radiological features associated with development of NF2. And to do that, we did this via a clinical questionnaire of 44 families with of patients with a ring 22 chromosome. Some were evaluated at our center at Greenwood, and then the remaining were recruited through national meetings and some of our international collaborations. Go next. So this is just to show you the clinical questionnaire that we used, and you could see, we asked about kind of the clinical diagnosis, how was that made, and then asked specifically about some NF2 associated symptoms, radiological changes, and then a family history. Next. So what did we find? So there are several things that came out of this study. The first was that really a ring 22 is not all that uncommon. So this is a table just showing all the genetic reports we reviewed from the registry of patients that could be at risk for a ring 22 chromosome. And so we excluded interstitial deletions and patients with variants in SHANK3, and that was 360 reports. So looking at all the patients that had a karyotype, you see that a ring 22 was present in about 33%. So prior estimation was only really about 15 to 16%, so this is a lot higher than that. Although something really that came out of this is you could see that about 60% of patients reported not actually having a karyotype despite having a terminal deletion. So, we assume a lot of this was that they never had a karyotype, but, we can't exclude the fact that also just because it was normal, they didn't upload it. So these were patient uploaded genetic reports. Next. So the second goal was to really describe the ring 22 patients and then prevalence of NF2 in those patients. And as you'll remember, we We interviewed 44 patients and families with a clinical questionnaire, and this is kind of what we found. We found that really a diagnosis of NF2 or NF2-associated tumors in these patients is really not that uncommon. In 7 out of our 44 patients reported having a diagnosis of NF2 or NF2-related tumors, so about 16%. The small cohort, but still, fairly high number, we thought. And interestingly, the average age at diagnosis of the ring was significantly greater in that group as compared to the group of individuals that did not have NF2. The average age at follow-up, so when we did the questionnaire, was 30 years old. And in the other group, the average age was 12 when we asked about follow-up. The deletion size the terminal deletion size between these two groups wasn't significantly different. Go next. So this is a general statement, but in general, neurological findings were more common in individuals with NF2. Although really the only statistically significant difference was in hearing loss, which you would expect, as the most common tumor in NF2 is a vestibular schwannoma, which affects cranial nerve 8. So you would expect those, in that population, their hearing would be affected. Nonetheless, this general trend was not overall that surprising, because as you'll remember, as I told you in the previous slide, the cohort of patients that had NF2 or NF2-related tumors were older in general. So you would expect maybe they had a little bit more of a complex phenotype and some other symptoms that they reported. Next. So this is just to show you that, and I'm sorry that got messed up in this slide. You can't see the percentages clearly, but that in most individuals with a ring 22 without NF2 actually did get intracranial imaging as part of their workup or screening, which was reassuring to us. The interesting thing was that actually in almost 50%, so about 40%, imaging was abnormal. And what you can't see is that in this pie chart, the largest thing, that light blue color of the abnormals, the most common thing that was found was an arachnoid or other benign intracranial cyst, which is, obviously most had this. Next. So really the last take-home point is that looking at all the 7 individuals with NF2 that we interviewed, really the clinical presentation is quite variable. So the first thing that you'll notice, and I'll draw your attention, is to the second line in the chart, the 3-year-old, and kind of diving in a little bit deeper into this patient, we found that not only did he have a terminal deletion, he actually had a more proximal interstitial deletion too, that included the NF2 gene that was inherited or congenital. So we would consider him to have the inherited form of NF2. So maybe kind of a little bit different in presentation than the other patients. Nonetheless, excluding him, the average age at tumor presentation was 25, but as you'll notice, the range is really wide, with the youngest being 15. And in congenital or inherited NF2, the average age of tumor presentation is in the 20s. So it's really not that much older than in inherited or congenital NF2, which was a little bit surprising to us, because you might expect that having mosaic loss of a ring and a second hit would occur at a greater age as opposed to already being born with a hit, the first hit, if that makes sense. Nonetheless, like I said, although the presentations were pretty variable, most of the patients, most of the patients that like you would expect, had a vestibular schwannoma, which is, like I told you, the characteristic tumor of NF2, and received some kind of surgery or radiotherapy. It's likely that these older age patients, actually the 39, probably presented, their tumors are probably there significantly earlier, because these are slow growing tumors, and when they presented pretty severely with multiple tumor types or hydrocephalus, so large enough to cause hydrocephalus, in other words. So you go to the next slide. So in summary, our take-home points from this analysis was that really the prevalence of ring22 in the Phelan-McDermid population is likely higher than previously believed. 33% is probably an overestimation. However, it certainly seems to be higher than previously thought. Ring 22 chromosome, ring chromosomes are important to recognize because of their association with NF2, and they're only identified via chromosome analysis. And this is important. So to realize that any karyotype should be recommended, therefore, in individuals with a terminal deletion, other complex translocations, to make sure that they don't have a ring. Next. Like I told you, NF2 is not uncommon. Tumorigenesis follows the classic two-hit model. The only really, in general, though there was more clinical and genetic features associated with the patients with NF2, really the only statistically significant finding was hearing loss, which you would expect. And then finally, the age and clinical presentation of NF2 in the ring population is variable. And so with that, we continue to recommend conservative screening based on our results. So that's cranial imaging starting at 10 years old and every 2 years after that, and continuing that for their lifetime. Consideration of spinal imaging, and then regular ophthalmological and audiology assessment. And next slide. So I just want to acknowledge the Greenwood Genetic Center Foundation, the Hope for 22q13 Gala, which helped support this project, and a special thank you to all the families that participated, and also our international collaborators who helped a lot with this project. Thank you.